Chapter 18, Cardiovascular System, the heart, and this is part 2. And we're going to start here with the intrinsic conduction system. The last lecture that we had ended with the extrinsic conduction system. So as a little review, remember that the sympathetic part of the autonomic nervous system, that speeds up the heart rate, and then the parasympathetic system works to slow down the heart rate, and that's by way of the vagus nerve. And remember that the vagus nerve, when it's attached, will actually keep the heart rate between 60 to 80 beats per minute. An interesting phenomena: if the vagus nerve is severed, heart rate goes up from 25 to 30 beats per minute. So this intrinsic conduction system is inside of the heart, and there are cardiac pacemaker cells that pass impulses in order across the heart, approximately 220 milliseconds. These are the 5 parts of the intrinsic conduction system: the sinoatrial node, also called the SA node; the atrioventricular node, also called the AV node; atrioventricular bundle, also called the AV bundle. Then it branches into 2 bundle branches, right and left. And then you have what are called the subendocardial conducting network, also called Purkinje fibers. I will probably refer to this as Purkinje fibers because that's what I developed as a term for this. So just excuse me, this is the newer term there. And these fibers go in between the cells and innervate the individual muscle that makes up the myocardium. So the way that this works is that you have the extrinsic conduction system, which works to control the sinoatrial or SA node, and the SA node is actually called the pacemaker of the heart. So that's stimulated, and that those cells are located within the wall of the right atrium. And then the signal is passed through the atrial cells, and then it goes to a structure that's called the atrioventricular or AV node. There's about a 1/10 of a second delay at that point, so that the whole atrial wall can be depolarized. And then the signal is passed from the AV node to the bundle. So this is where you actually have the connection between the atria and the ventricles. They are separate chambers, these chambers of the heart. The atria are separate from the ventricles. The connection is purely electrical. So the atrioventricular bundle connects the atria to the ventricles. Then the signal is transferred down to the bundle branches. So it conducts the impulses through the interventricular septum. And then they go down to the apex of the heart, and then they divide, and the one side of this subendocardial conducting network serves the left side of the heart muscle wall, and then the other side takes care of the right side of the heart. And because the left side of the heart, the wall is much thicker in the left than in the right, you find a more extensive Purkinje fiber network in this part of the heart. So when we look at microscopic anatomy of heart muscle, we know that cardiac muscle cells generally are striated, so they have the striped appearance. They're short, they're branched, they tend to be fat, they're interconnected. Most of them have 1, some have 2 central nuclei per cell. There is a connective tissue matrix, which is called the endomysium, that connects to the cardiac skeleton. There are numerous capillaries within cardiac muscle, and then some of the anatomical differences, not something you need to really focus on, but the T-tubules are wide, they're less numerous, and the sarcoplasmic reticulum is simpler than that of skeletal muscle. And there's numerous large mitochondria. Actually, the mitochondria makes up about 25 to 35% of cell volume. And this is important because skeletal muscle has about 1 to 2% volume is mitochondria. by having this great number of mitochondria, it allows a continuous supply of ATP to be produced, so that makes cardiac muscle fatigue resistant. Now here's the cardiac cycle. The cardiac cycle is the time that it takes for the blood flow to go completely through the heart in one complete heartbeat. You have atrial systole. Systole means contraction. Diastole means relaxation, followed by ventricular contraction, systole, and relaxation, diastole. That's the cardiac cycle. So just keep in mind, systole means contraction, diastole means relaxation, and this cycle is performed by the different blood pressures and volume changes that occur in the heart. Some of the homeostatic imbalances that you can see in this intrinsic conduction system are things that are called arrhythmias. An arrhythmia is just a general term for an irregular heart rhythm. So you have uncoordinated atrial and ventricular contractions. And the word fibrillation means an excessively rapid, irregular contraction of the heart. And at this point, the heart is really just fluttering and the blood sloshing back and forth in the chambers, but it's not being pumped anywhere. So there's no sequential atrial contraction, ventricular contraction, it's just fluttering. So blood's not being pumped, circulation ceases, and it can result in brain death. So defibrillation is the treatment to try to trip the heart back into its normal rhythm again. Now at the top of page 4 of the notes, there are some different homeostatic imbalances mentioned there. PVCs, premature ventricular contraction, or extrasystole can be caused by hypoxia, electrolyte imbalance, nicotine, other drugs, caffeine can do this. Ectopic focus is something where the SA node's not working. So if the SA node's not working, the AV node can take over. And if the AV node takes over, it sets what's called junctional rhythm, which is slower than normal heartbeat rhythm. The normal heartbeat, remember, is 60 to 80 beats per minute. So if you have ectopic focus and the AV node is working, then it slows it down to about 40 to 60 beats per minute. That's why a heart rate of less than 60 beats per minute is of diagnostic value, because it could mean that your SA node is not working. Nodal rhythm is what's referred to as a rhythm being controlled by the AV node, and I mentioned that on the notes too. And the term arrhythmia is there, and then there is a little discussion about heart block. So extrasystole is a premature contraction. Ectopic focus ends up setting a high rate and can be from excessive caffeine or nicotine. So these are PVCs, PACs. So to reach the ventricles, the impulse must pass through the AV node. Now, if you have a defective AV node, this could cause heart block, where a few partial or no total impulses reach the ventricles. And the ventricles beat very slowly, in this case many times, too slow for life to continue. And at this point, an artificial pacemaker is needed to address the problem. Now this is looking at something called the absolute refractory period in cardiac muscle. What happens here is you have the contraction phase. So this is 1. This is the depolarization phase that's going on in the heart muscle. So depolarization is due to calcium influx through fast voltage gated sodium channels. And this sets up a positive feedback mechanism to open many more channels, and it reverses the membrane potential. So what's happening here is you're letting sodium in, and it's positively charged, so this negative charge that existed before the depolarization phase now starts to become more positive. The plateau phase that you see here, and it can be as much as 250 milliseconds, this is the absolute refractory period. See how long it is? And that absolute refractory period is due to calcium influx through slow calcium channels. This keeps the cell depolarized because there aren't any potassium channels open. So in skeletal muscle, the absolute refractory period is only about 1 to 2 milliseconds, which means that you can actually clench your fist and maintain a contraction. But you wouldn't want the heart to do that. The heart needs to go through its complete cardiac cycle, and the average cardiac cycle is about 0.8 of a second. And so in order to prevent tetanus, like you could do with your fist by making a fist and holding it, you have this long absolute refractory period of almost 1/4 of a second, or 250 milliseconds, to allow the heart to go through its cycle before it actually can receive another stimulus. So the repolarization phase now, number 3, is due to calcium channels inactivating and potassium channels opening. This allows potassium efflux, potassium goes out, which brings the membrane voltage back to its resting voltage. So this is similar to skeletal muscle. What happens there, we talked about that in chapter 9, but you've got this long absolute refractory period, and that's important for preventing the heart from going into sustained tetanic contraction. So let's go through this. This is functional differences between cardiac and skeletal muscle. The means of stimulation, each individual skeletal muscle cell must be stimulated independently, whereas cardiac cells respond as a group. They have gap junctions, so the signal spreads between the cardiac muscle cells and they all work together. The atria all contract together, the ventricles all contract together. It's an organ versus motor unit contraction. Heart acts as an organ. Skeletal muscles operate under the motor unit type of contraction. In skeletal muscle, all the cells of a given motor unit contract at the same time. Impulses do not spread from cell to cell. In the heart, it contracts as a unit or it does not contract at all, and this is via the gap junctions. So you can get different degrees of tension in skeletal muscle, where the heart, it's all the same. Length of absolute refractory period, what we just went over. The inexcitable period when sodium channels are still open or are closed or inactivated. Remember, 250 milliseconds in cardiac muscle, 1 to 2 milliseconds in skeletal muscle. And this long refractory period in cardiac muscle prevents tetanic contractions, which would stop the heart's pumping action. The sequence of electrical events in contractile cells, very similar to skeletal muscle with a few little wrinkles, but sodium ions enter the cardiac cells. Depolarization occurs when you go from negative 90 millivolts inside the cell membrane to plus 30 millivolts. This propagates the action potential. Then you get the transmission of the depolarization wave down the T-tubules, which causes the sarcoplasmic reticulum to release calcium into the sarcoplasm. Excitation, contraction, coupling occurs as calcium propagates the signal by binding to troponin, cross-bridge activation, and sliding of the myofilaments. Now we're going to move on to electrocardiography. Now the electrocardiogram, ECG or EKG, is a composite of all the action potentials generated by the nodal and contractile cells at a given time. Now these are electrical events. They're not the actual contraction of the muscle itself. It's not the movement, it's the electrical changes that are represented by these waves. So there are 3 waves. The P wave represents the depolarization of the atria. Then the QRS is when the ventricles depolarize, and because the atria are repolarizing during the same place at the same time, atrial repolarization is buried in the louder signal of the QRS because the ventricles are a bigger muscle, it's a louder signal. So both events are happening simultaneously in this one large peak. And then the last event is the T wave, which represents ventricular repolarization. So here's a look at the heart, what's happening intrinsically through that the 5 parts of the intrinsic conduction system, starting with the SA node, then to the AV node, the bundle branches, the Purkinje fibers, and showing you here the printout of the electrocardiogram. So the P wave represents atrial depolarization. And then you have this little segment here. A flat place is called a segment. And that is where the actual atria physically contract. Now, an interval is the time that encompasses a wave and a segment. That's called an interval. And this also completes what's happening in the atria. So it gives you atrial depolarization followed by atrial contraction, the contraction of the muscle. Then you go into the QRX complex. And the QRX complex is where the atria are going to repolarize and the ventricles actually depolarize. After you get the depolarization of the ventricular muscle, then the ST segment is where the ventricles physically contract. After they contract, then the muscle repolarizes. And this whole interval here, this QT segment, encompasses what's going on in the ventricles. And you can see that the whole cardiac cycle really is 0.8 of a second, from atrial depolarization all the way through ventricular repolarization. This is what the tracing paper that you see in the hospital actually looks like in an ECG. Each one of these little squares represents a time period of 0.04 seconds. So there's 20 little blocks that go across to make up 0.8 of a second. And showing you again what's going on, showing you where the atria contract, where the ventricles contract, and labeling all the different waves and segments. This picture is great because it's giving you a picture, an illustration of what's going on in the heart with where you're at in the electrocardiogram. So number one, you see that the yellow refers to depolarization, the red is repolarization. So atrial depolarization begins the process with the SA node, and this depolarization wave spreads throughout the atria. It's initiated by the SA node and it causes what we call the P wave. Then, with the atria being completely depolarized, the impulse is delayed at the AV node, and this allows the atria to contract. Ventricular depolarization begins and it spreads down to the apex, and it causes the QRS complex. And you see here at the same time, atrial repolarization, it's red now, is occurring. So that's in this QRX complex. When ventricular depolarization is complete, at this point, ventricular contraction occurs. Then that's followed by ventricular repolarization beginning at the apex, causing the T wave, and then ventricular repolarization is complete, and then you're back to the beginning again. So that's all the sequence of the depolarization and repolarization events that occur in the heart related to the deflection waves in the ECG tracing. This is a look at different types, different ECGs, and some problems. This is normal sinus rhythm. You see your P wave, your QRS, and your T. Here you have what's called junctional rhythm, where the SA node is non-functional. P waves are absent because the SA node isn't working, and the AV node paces the heart at 40 to 60 beats per minute. And if you look at the number of QRS waves in this tracing compared to the number here, you see there are fewer. Second degree heart block, some P waves are not conducted through the AV node, hence there's more P's than QRS waves are seen. In this tracing, the ratio of P waves to QRS waves is mostly 2 to 1. So you see you have, let me see if I can find one here, PP, QRST, PP, QRST. So it's taking 2 impulses to get the signal through. And again, you're not seeing as many QRS peaks here as you do up here. This is a mess. This is ventricular fibrillation. Chaotic, grossly irregular ECG deflections are seen in acute heart attack and electrical shock. There is no rhythm. There is no pattern. And like I said earlier, the heart is just really quivering. You're not getting any blood being pumped to the body or to the lungs, and the patient can die. Now, heart sounds. There are 2 sounds we refer to as lubbed up, associated with the closing of the heart valves. The first sound you hear is when the AV valves close, and that's the beginning of systole. It would be ventricular systole, when the ventricles are actually beginning to contract. The second sound is when the semilunar valves close, and that's the beginning of ventricular diastole. Okay, so the AV valves close first, then after ventricular contraction, then the semilunar valves close to prevent backflow of blood into the ventricles. The pause indicates the heart relaxation. Heart murmurs are abnormal heart sounds, and they usually indicate incompetent or stenotic, meaning hardening stiff valves. There's a lot going on in this picture, and you want to take some time with it. If you get it, if you can print it out in color and use it as a guide, what it's showing you here is it's showing you all the deflection waves, the electrocardiogram here, where the heart sounds are occurring. These are blood pressures, this is blood volume, and then these are when the valves are open, close, and these pictures at the bottom reflect what's going on in the heart. Now, the cardiac cycle has three major parts. One is ventricular filling, the other one is ventricular systole, and the last one is diastole. Okay, so you have to fill up the ventricles, then you contract the ventricles, and then they rest. Okay, so you kind of have to realize that these pictures are skewed. Okay, so this one really goes over here, that one kind of goes over here, and this one goes here, that one goes there, and this one goes here. So you have to make sure you line them up right. Okay, so just briefly, these are the pressure changes that occur in the heart. And so when the ventricles are contracting, the pressure is going to go up. Normally in the heart, when it's relaxed, the pressure in the aorta and the systemic circulation is 80. Okay, 120 is the high number, and the high number is when the ventricles contract. This dichrotic notch is the brief drop in pressure that occurs when the blood tries to come back into the ventricles, but the semilunar valves close and then it rebounds off of those valve flaps. So there's a slight drop in pressure there. That's the main thing. Here is the volume in a ventricle, a typical ventricle. So a typical ventricle, when it's full, ending diastolic volume means the volume when the ventricle is full is about 120 milliliters of blood. After the ventricles contract, here, what's left is called the ending systolic volume, what's in the chamber after the ventricle contracts. So you start out with 120 and you end up with 50 being left. So each time the ventricle contracts, you actually eject about 70 milliliters of blood, which is a little bit more than 2 ounces because there's about 30 ounces in a milliliter. So you're ejecting 70 milliliters, so that's a little over 2 ounces. So about a quarter of a cup. So the stroke volume is found by taking the ending diastolic volume and subtracting out the ending systolic volume. And stroke volume is very important. We'll see that in a minute. So spend some time with this. See if you can connect how everything fits together. And very, very good diagram, but a lot in it. Now, homeostatic imbalances of the heart, congestive heart failure, is a progressive condition. Cardiac output is so low that blood circulation is inadequate to meet the tissue needs. Reflects weakened myocardium caused by some of these conditions, like coronary atherosclerosis, which is a clot where the arteries become clogged, persistent high blood pressure, multiple myocardial infarcts, which weakens the cardiac muscle, or dilated cardiomyopathy, also referred to as DCM. And this is where the heart is unusually enlarged, usually starts in the left ventricle, and it's predominant in young men, common in young men, usually 20 to 60 years of age, and 1 in 3 cases of CHF is due to DCM. So you're probably going to run into this a lot, and it's a genetic, inherited genetic mutation to cardiac muscle proteins. So those are some of the conditions that can result in congestive heart failure. And let me just say this. If you have left-sided heart failure, that means that the heart's not strong enough to pump blood to the systemic circulation. And where you have backup is you have backup in the lungs. So you'll have lung congestion with left-sided heart failure. Right-sided heart failure, you're not able to, the right side of the heart's not strong enough to pump blood to the lungs. And where you'll see backup in the circulation is in the peripheral circulation. So you'll see swelling in the ankles, you'll see swelling in the hands. So right-sided heart failure is peripheral congestion, left-sided heart failure, backup of fluid in the lungs. So I just wanted to mention that because you will see that a lot with patients. Cardiac output is the volume of blood pumped by each ventricle in 1 minute. And the formula for that, for cardiac output, is you take the heart rate and multiply it times the stroke volume. So heart rate is the number of beats per minute. We said it was 60 to 80, right? And stroke volume is the volume of blood pumped out by one ventricle with each beat. So what we're going to use for heart rate for this formula is 75 beats per minute. And the stroke volume we got from the previous slide, which was 70 milliliters. And if you take 75 for the heart rate times 70 for the stroke volume, you will get 5,250 milliliters per minute, which is the same as 5.25 liters per minute. So that's normal cardiac output, a little over 5 liters of blood per minute. So at rest, cardiac output, milliliters per minute, heart rate, 75 beats per minute, times stroke volume, 70 beats per minute. There's your formula all spelled out for you. And cardiac output increases if either or both stroke volume or heart rate is increased. Maximum cardiac output is 4 to 5 times resting cardiac output in non-athletic people. But if you're a trained athlete and you have improved your cardiovascular fitness and the strength of the cardiac muscle, maximum cardiac output may reach 35 liters per minute in trained athletes. And a cardiac reserve is the difference between the resting and the maximal cardiac output. Okay, so tachycardia is an abnormally fast heart rate. It usually refers to the heart beating faster than 100 times per minute. And if persistent, could lead to fibrillation. Bradycardia is a heart rate slower than 60 beats per minute, and it may result in grossly inadequate blood circulation in non-athletes. But it may be a desirable result of endurance training. These are some of the things that affect the sympathetic or the extrinsic autonomic sympathetic response. Nicotine will increase heart rate by increasing the amount of norepinephrine that's available, and that's going to increase this pathway here. The pathway is a cyclic AMP pathway. Caffeine prevents its breakdown, which again will result in increased heart rate. And what this pathway does is cause increased calcium release from the sarcoplasmic reticulum, which results in an increased heart rate. Some of the electrolytes that have an effect on the heart, hypocalcemia, low calcium will depress the heart rate. Hypercalcemia will increase the heart rate and contractility. Hyperkalemia refers to potassium, and too much potassium can alter the electrical activity of the heart, resulting in heart block and cardiac arrest. What happens is too much potassium outside the cells, it comes into the cells, and it makes the cells hypopolarized. So hyperkalemia causes hypopolarization of the heart muscle. Hypokalemia, too little outside, will result in potassium moving out from the inside, which can actually hyperpolarize the heart muscle, and it results in a feeble heartbeat and can produce arrhythmias. So interesting fact here that both hyper and hypokalemia can result in disruptions of heart function, and it's because potassium is fairly diffusible through the cell membrane. So regulation of stroke volume. Stroke volume is determined by taking the ending diastolic volume when the ventricle is full, and we said that was about 120 milliliters, subtract out what's left, that's the ending systolic volume, which is about 50, and our stroke volume is 70 then. Ending diastolic volume is affected by the length of ventricular diastole and venous pressure. So how long the ventricle has to fill up. The longer that it has to fill up, you'll have a greater ending diastolic volume. It'll be fuller. Ending systolic volume is affected by arterial blood pressure and force of ventricular contraction. So how much can you actually pump out and how much you're going to have left. So the more you pump out, then the less you'll have left over. Things that can affect stroke volume: preload, contractility, afterload. So contractility comes from increased sympathetic stimuli. Okay, so that's going to increase the heart rate. Certain hormones like thyroxine, norepinephrine, epinephrine work to increase heart rate and contractility. Calcium, too much calcium, remember, can increase heart rate. Some drugs, well, amphetamines, speed, Adderall, I mean, there's different medications that can work to increase contractility. Decrease in contractility comes from acidosis, and here's why. Acid is caused by the increase in hydrogen ion concentration. So if you have too much hydrogen, the cells will take in the hydrogen. In exchange, they'll kick potassium out. And we know potassium is normally found inside the cells. So when you kick potassium out, increase in potassium depresses the heart rate. So going from acidosis, the exchange of hydrogen ions, that will do it. And also just an increase in extracellular potassium as a whole. This will cause increased extracellular potassium, and that is just other means of having too much potassium. It could be some kind of imbalance with sodium causing that. Calcium channel blockers, which are used to treat people that have excessively overstimulated hearts, could be due to a stress response, could be due to overactive sympathetic events, oversympathetic stimulation of the heart. So calcium channel blockers work to keep the heart rate down. So these are just some things that increase and decrease the heart rate. And then as you age, these are changes that affect the heart. Sclerosis means a hardening of the valve flaps, makes them stiff. They're not as flexible. They also thicken up. Cardiac reserve goes down. As we age, we lose cardiac muscle cells. Those cells are not replaced. Cardiac muscle becomes fibrotic because fibrous tissue replaces the tissue that has been lost over the course of time. And atherosclerosis is the building up of plaque on the inside of larger vessels, which will increase blood pressure and reduce the functioning of the cardiovascular system as a whole. So that is the end of chapter 18.